It's Dr. Sabrina Siegel here with a special series brought to you by the NEI Podcast. Welcome to the PsychopharmaStahlogy show. In this special series, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today. Every 3 months, we will address a different theme in psychopharmacology. Each theme is split into 3 parts, with 1 part released each month. The next theme is on novel perspectives and treatment strategies for ADHD. Today, Dr. Andy Cutler interviews Dr. Stephen Stahl on the role of serotonin in medications for ADHD, non-traditional approaches to treating ADHD, and what the future holds. Let's listen in to part 1 of our theme, Shifting Focus, a novel perspective on Attention Deficit Hyperactivity Disorder.
Welcome to another podcast in the PsychopharmaStahlogy series. I am Dr. Andrew Cutler, here today, of course, with the inimitable Dr. Stephen Stahl, and we're going to be talking today about a novel perspective on ADHD. You know, recently we have learned a lot more about the neurobiology of ADHD. We have new treatments in development. So, Steve, how are you doing today?
Inimitable, evidently, according to you, so I'm doing great.
Well, it's a word I just learned. I figured I would use it, you know. It's a good SAT word. Yeah, my son just took the SAT, so I guess that was on my mind. All right. Why don't we start out a little? What has been the traditional dogma of the neurobiology of ADHD? How have we conceptualized this?
Well, in the old days, it was paradoxical conceptualization. Why would you want to give a stimulant to somebody to slow down? So exactly. People say, well, how did it make it? Well, there was something wrong with the circuitry that somehow that more was better and yada, yada. It was a lot of hand waving. Nobody really understood it. And so if you think about it as a striatal issue, which is motor in the striatum of the brain, it doesn't make sense that increasing stimulants maybe at that level is going to be as effective and may even be the wrong direction because you're already wired and going too fast anyway. So it's really transferred in modern days to a problem in the prefrontal cortex, and that maybe it's a neurodevelopmental problem in the way the cortex is organized that starts really, early in childhood or birth even, and that sometimes you, quote, outgrow it, but often you don't. So it's a neurodevelopmental abnormality of the prefrontal cortex.
Well, that really makes sense. So we think of it more as a top-down problem, I guess, and that has always been a paradox, a conundrum for a lot of people. You take a hyperactive kid, you give them speed, essentially, and they calm down. But I guess we can think of it as turning on the prefrontal cortex and allowing it to regulate or modulate the striatum better.
In the case of the motor, you're probably having top-down inhibition. And same thing with impulses. You have drives that are subcortical, and if they're not being sort of ridden hard and put away wet, if you will, if you're a cowboy, I guess. I'm thinking of riding horses today. But, it would inhibit it, then they're out of control. Now, the inattention and the cognitive stuff is a little differently and more sophisticated, but top-down control of motor impulsivity and other type of behavioral impulsivity, that's probably what's happening.
Well, as we know, the prefrontal cortex has different regions and probably has different circuitry. We know that, for instance, that the dorsolateral prefrontal cortex is involved probably with attention and executive function, and the ventromedial, for instance, is involved with emotional regulation. And then there's a part that there's a circuit that's involved with motor activity and impulsivity. So, it really sounds like there's 3 important circuits here. So there should be 3 clusters of symptoms. But Steve, last time I checked in the DSM, there's only 2 clusters of symptoms.
Yeah, but, you can finesse that a little bit. For example, the orbital frontal cortex may be involved with impulsivity, and so that's more emotional, whereas the ventromedial prefrontal cortex may be involved with emotions that are less impulsive, but in fact may not even be so much in the ADHD realm, but things like guilt and sadness and things like that. And I always like the rap song. One of our silly YouTube videos we once did, the DLPFC, the dorsolateral prefrontal cortex. And that's really where a lot of the money is for cognition. It has to do with executive function. And so when you're not actually problem solving well, it's called executive dysfunction. Now, you could say that is actually something once you arrive in Washington, D.C., you end up getting executive dysfunction from having been elected to office. But that's a different type of executive dysfunction we're talking about. The executive dysfunction that we're talking about here is one in which you can't hold enough information in your brain to operate on it to solve a problem. And so it's sort of like your RAM memory. You got to load stuff up and operate on that. Then you can figure the solutions inside that information. People with ADHD can't hold that. They lose their focus. They are distracted and things like that. So there's also the anterior cingulate cortex can be involved a lot with attention as well as at least paying attention and holding attention, and called selective attention. But there's a funny thing about attention. If you actually are too focused, you don't actually switch attention when you should be, and you basically are out of whack. So basically, you're right. It's various types of connections between the various regions of the prefrontal cortex and the subcortical structures, each of them kind of mapping to a different symptom complex.
Yeah, I've done a lot of work with ADHD, both clinically and lots of clinical trials. And what you're describing makes a lot of sense with the clinical presentation. These people have a lot of trouble with working memory and sustained attention, but also executive function. They don't plan ahead well. They don't have sometimes good self-monitoring, self-awareness, judgment. They live intensely in the moment. They don't always consider the consequences of their actions. So that really fits, Steve, clinically, what's going on.
Well, many of us in today's world have to be able to multitask. Now, if we multitask to a fault, we actually pay no attention to anything and we don't get anything done. But obviously, it's true that your device goes off, you're on the screen, you're looking at that. Maybe you're reading something and you may be thinking of more than one thing. And so, multitasking is required in today's technical world.
Well, that's certainly true. And I find, these people, they can pay attention, they can orient to stimuli, but they can't sustain it. And it seems that they have interest-based focus rather than priority-based. Someone who doesn't have ADHD can say, well, this is important, I need to focus on this. But with ADHD, it's, well, this is important, but hey, look at that. That's interesting over there. I'll get back to that important thing. And then they procrastinate because they have no sense of time. I also like what you said before, Steve. I think the 4 words that comprise the name of this condition are absolutely wrong. All 4 of them. This is not attention deficit, because if somebody's interested, they can lock in and hyperfocus, and then they actually have trouble shifting attention. This is not necessarily hyperactivity. You can have the predominantly inattentive presentation. And I don't think it's a disorder. I just think it's different wiring. It's different ways of processing information. There's some things the ADHD brain does very well, and there's some situations ADHD brains thrive. It's just school is not one of them. You get stuck in school when you're a kid.
Yes, and there's probably cognitive training, whether you even know that that's what you're doing. You learn how to overcome that. Certain types of effort that you can give will do that.
Also, I had a professor, Steve, who used to say IQ points can compensate for a lot. And very often I find bright kids or kids who have a mom who can really compensate, they don't come to attention till much later. Often when they're going off to college and then they have to organize for themselves and more cognitive demand and keep track of things, and then the wheels fall off.
Absolutely. You end up seeing an explosion of ADHD diagnoses in freshman college.
Yeah. This is one of the reasons DSM-5, a lot of us think DSM-5 didn't go far enough and didn't really evolve the criteria for ADHD enough based on what we now know. But at least one of the good things was in DSM-4, Steve, you had to have symptoms before the age of 7, meaning 6 or below. Well, how many adults can remember what they were like when they were a 6-year-old, right?
Yeah, exactly.
How many adults have a copy of their nursery school or kindergarten report cards lying around? So, So the good news is that the DSM-5 upped the cutoff point for till the age of 12, symptoms before the age of 12. And that actually makes a little sense because that's when middle school starts. And now you start having to move from classroom to classroom. You have more homework, more cognitive demands. There's still people who think that sometimes someone can be compensated and may not have big problems, but the symptoms are usually there.
Well, if you're a little boy and you're crawling on the desk, you're hyperactive. So this usually be just called hyperactivity. And that's easy to diagnose. Those kids are running all over the place, usually boys, and they're usually young. But like you say, some of the inattention, particularly if you have a lot of IQ points, isn't really uncovered until the extra effort and the extra intelligence is basically overcome by the cognitive load, if you want to call it that.
Yeah, that's certainly true. This was originally conceptualized, as you said, as a hyperactive disorder. As a matter of fact, it was called at one time hyperkinetic reaction of childhood. Now, sadly, it was also called minimal brain damage or minimal brain dysfunction at one point. And that really came out of the one of the influenza pandemics where people who got influenza encephalitis or meningitis, they ended up looking like these hyperactive kids. And so people thought, well, there must be some kind of brain damage that we just can't see here or some minimal form of brain damage. But clearly our understanding has evolved to incorporate inattention and some of the other associated symptoms. And you're right that in childhood, ADHD gets overdiagnosed in boys because they tend to be more hyperactive and get into trouble. And then the inattentive girls are sitting in the back of the classroom, spacing out, not causing trouble. And they end up coming to attention later, often in adulthood.
Well, one of the terrible misconceptions that you can talk about for girls is they get diagnosed as being blonde. Being nasty
spacey.
Here. Spacey girls, and that, and it isn't until they go to college when they really start to follow back cognitively and performance that it's like, oh my God, this was ADHD, but this was not an impulsive nor a motor hyperactive person. It was mostly inattentive. So a lot of girls are not diagnosed, hopefully less so today as people are aware of what we're talking about here, because it comes in that flavor. The flavor is mostly inattentive. They're quiet. They don't bother anybody. They just can't get their homework done.
Yeah. Now, I've seen some hyperactive girls too, so you can see it, but you're right. It's far more common in attention. But, if you think about it, Steve, who keeps track of the household? Who makes sure that the husband and the kids go to the doctor and take care of things? And all that tends to be the woman, I'll be honest. Not always, but often it's a woman. So if a woman is having trouble, who reminds her of things? Who keeps her in line and in track, right? So often it comes to light later. And then
there's a lot of growing multitasking again. We were talking about multitasking. Who multitasks more than a mother?
That's so true. And with the COVID pandemic, now all of a sudden, you have to your kids are home from school doing virtual school, and maybe you have a job and school. I mean, the wheels fell off for a lot of people. The fastest growing group of people being diagnosed now, Steve, is women, by the way, which is interesting.
I didn't realize that. Well, that makes sense, though.
Yeah.
Yeah. And so, the idea is there's something about the maturing of the prefrontal cortex, which is slower and maybe never quite normalizes. And that's really the dynamic. There's no holes in the brain. It's not like minimal brain damage dysfunction. It's really, there's no lesions you can see under the microscope. But it's thought that the circuits are inefficient in information processing.
Yeah, you're absolutely right. There's a classic article by Philip Shaw and colleagues that demonstrates this. They followed developing kids' brains, and they found that kids with ADHD, their cerebral cortex, especially the frontal part, is delayed by up to 1.5 years in development compared to controls. What's interesting is the area that developed faster on average was the motor strip, the primary motor strip. And this really is fascinating. And then the areas that have to do with intelligence, of course, were right on target. So you can be very intelligent and still have this condition. That's a myth people have. Well, we've learned more about the neurobiology. And, well, let's first of all talk about, again, the dogma sort of is, a lot of times in psychiatry, it seems like we propose pathophysiology based on how our effective medicines are shown to work, right? For years, depression was a serotonin problem, too little serotonin or something like that. Now we know a lot more. Well, same here. All of the medicines that have been shown to be effective are increasing dopamine or norepinephrine function. And so we understand there's got to be something wrong with dopamine and norepinephrine transmission, right?
Yeah, and turns out that the prefrontal cortex is critically dependent upon the correct, if you will, tuning of norepinephrine and dopamine in what we would call the pyramidal neuron, which is one of the major captains of the circuit. And so if you don't have efficient use of that circuit, then you're either slow or it doesn't get done. And turns out that usually norepinephrine and or dopamine are too low. Now that's an overgeneralization, but that it turns out that the way you tune the circuit is to increase those neurotransmitters. And it's interesting because there's dopamine and norepinephrine increase, but in the cortex, you don't actually increase dopamine by doing anything to a dopamine neuron directly. What? It's very interesting. There's no dopamine transporters really in the prefrontal cortex to speak of. So if you have something like a dopamine reuptake blocker, it doesn't do anything in the cortex because there's nothing to block. So then how does dopamine go up? Well, the answer is that, if you can believe it, the norepinephrine transporter not only transports norepinephrine, no duh, it also transports dopamine. So the way that dopamine actually gets terminated in the cortex is that it's allowed to cruise away from the dopamine synapse in a puff in a cloud, sort of like in a cell phone radius, until it reaches a norepinephrine transporter, which then sucks it up like a vacuum cleaner and terminates its action. So guess what? If you block that transporter, you will enhance even further the actions of dopamine in the cortex. So it's really norepinephrine transport inhibitors in the cortex that have a great deal to do with the enhancement of efficiency of information processing of both dopamine and norepinephrine just by hitting the norepinephrine transporter in ADHD.
Got it. So dopamine hitches a ride on the norepinephrine transporter in the prefrontal cortex. But of course, in other parts of the brain, the striatum, there are dopamine transporters. So this is interesting. The norepinephrine reuptake inhibitors aren't doing much then with dopamine in the striatum. And maybe that's why they don't seem to cause the same buzz, euphoria, high, the same.
Well, the
problems.
other thing is dose. So that, to tickle the norepinephrine transporters in the brain, because really amphetamines and stimulants are dual acting. They act on both dopamine and norepinephrine transporters. So how can this drug, which also in another form of methamphetamines causing one of the worst epidemics of drug abuse in the country, also be therapeutic? Does it make any sense to you? And the answer is dose, dose, and dose. Because to whack the heck out of the striatal dopamine receptors so that you have euphoric trip or joy or abuse, you have to have much higher doses than you use to treat ADHD. So generally speaking, you're under the radar for that. And so you get norepinephrine in the cortex, dopamine in the cortex, but you don't get a whole lot of dopamine in the striatum, which you maybe get enough for a little motivation, but not, hopefully, enough to actually be abused.
Yeah, it's also potency. I mean, we know that methamphetamine, crystal methamphetamine, is much more potent at releasing dopamine, and that's why it's abused. Something else is curious, Steve. While both methylphenidate and amphetamine block the reuptake of norepinephrine and dopamine, isn't there a difference? Amphetamine does something else, especially as you raise the dose.
You mean it causes release?
Yeah, it flips the transporter around, it blocks VMAT, you get release of dopamine.
Yeah. And what's interesting is that occurs when you really blast the dopamine neuron, as you say. And what's interesting about that is that not only is the difference between a therapeutic use of these agents different from the abuse by dose, it's also by duration. Because there's nothing greater to release dopamine, like you say, and open up those channels and not only block reuptake, but spit all the dopamine, like wring it out of that dopamine neuron fast. It's to whack it real hard. So why do you think that oral amphetamine isn't abused as much as IV amphetamine isn't abused as much as smoking amphetamine or cocaine? Because you can imagine if you laid out the surface area of your lung, it'd probably cover the whole wall in front of you. That's how much surface area your lung has. So when you smoke something, it goes into that, gets absorbed in like a huge ram, goes up your carotid artery and blasts your brain full of this reuptake inhibition. And that is a very different pharmacology. It's mostly dopamine at that point, less so norepinephrine. It's mostly sudden dopamine. It's mostly dopamine release. And then all of a sudden, a glorious cloud of dopamine comes out. What you're hoping to do with controlled release, which you're seeing more and more all the time, with even at the low levels of dosing that we're seeing, there's a huge difference. It's almost like it's two drugs. Amphetamine given in controlled release is much different than amphetamine given in immediate or even smoked. So it turns it into a different drug. And the drug we want is the controlled release, more noradrenergic, less dopaminergic, more cortex, less striatum.
Yeah, and this is, of course, why Adderall immediate release, for instance, is the drug of choice. I've always noticed that on the street, street value tells you a lot. Addicts are connoisseurs. Adderall has a much higher street value than, say, Ritalin or methylphenidate. And that's because of what we're talking about. You get much more of a burst of dopamine, especially as you push that dose up higher.
Well, it's going to be interesting to see what the listeners think about that, because, the dopamine of Adderall means, what if a patient comes in with no prior diagnosis and no history and is an adult and doesn't remember or won't tell you what happened earlier and wants immediate release Adderall as the first prescription when they come to your office? Well, I guess it's in the standard of care and it's in the treatment algorithms, but I would say no. And because of what you say, is that the abuse, the liability, or it's not even so much abuse, it's almost misuse and diversion, giving it to other people. So, it's not as much fun to take an immediate release stimulant because the glory of that whacking the transporter, you can't do it with a controlled release.
Right. Well, I would say standard of care now, especially for adults, is extended release. There's no question about it. I would not give somebody immediate release in that scenario that you described. Particularly if people come in asking for it by name, that's always a red flag. But you're right, there's concept of abuse, misuse, and diversion. Those are the three things, and they're slightly different. But, getting back to this difference between methylphenidate and amphetamine, they have those similarities. They both block reuptake, but the amphetamine is more potent, basically. You get more dopamine release. And while most patients will respond to either one, there is preferential response. About 30% of people will do better with one than the other. They may need that potency of amphetamine, or they may have trouble tolerating it because amphetamines are more likely to cause irritability, appetite suppression, and insomnia. So one of the points for our clinicians listening is, look, if you've tried methylphenidate after methylphenidate and you're not getting response, switch over to an amphetamine or vice versa. You always have to try both.
Yep, absolutely.
All right. Well, let's move on here. So obviously, dopamine, norepinephrine, the prefrontal cortex, by the way, loaded with D1 receptors, loaded with alpha-2A and alpha-2C receptors. We do have a class of drugs, while we've been talking about reuptake inhibition, increasing the amount of norepinephrine dopamine, we do have a class of drugs, the alpha-2 agonists, that bind directly to those norepinephrine receptors, guanfacine and clonidine extended release in particular. So what about those?
Well, we're beginning to see that maybe those receptors have maybe a bit more to do with impulsivity and aggression and even agitation than they do with cognition per se. One of the things that we do see is when children particularly have some behavioral disorders, that's sometimes when you go to the guanfacine or the clonidine and target some of that. And it turns out that other agents that play upon the alpha-2 or even the alpha-1 system to shut down some of that excessive norepinephrine is being used in agitation. For example, there's an alpha-2 agonist called dexmedetomidine that is actually useful in the agitation of bipolar and schizophrenia being tested in Alzheimer's agitation now, and I'm wondering if it's being tested in ADHD, because it would seem like that might be useful. Except it's a PRN med, and it's just a little tape that you put under your tongue, but it might be useful on that basis. And then also a drug like brexpiprazole, which has alpha 1 antagonism, shutting down norepinephrine, has shown to be useful in the agitation of Alzheimer's disease, possibly getting an FDA approval in the next year. So playing on the alpha receptor could actually improve agitation and aggression, maybe attention, but certainly agitation and aggression and impulsivity.
Well, it gets back to the idea we talked about earlier of top-down regulation. ADHD and Alzheimer's and schizophrenia and bipolar all have problems with top-down regulation. And so then you get this overactive limbic system, if you will. What's interesting, Steve, is the alpha-2 receptor is fascinating. There's alpha-2A and alpha-2C. Alpha-2B does other things, but alpha-2A is postsynaptic. Alpha-2C tends to be a presynaptic autoreceptor. And where the lowering blood pressure comes from is the presynaptic alpha-2C, which in the locus ceruleus tones down norepinephrine release. So that's exactly what we want to do for agitation. Alpha-2A, though, postsynaptically in the prefrontal cortex, Amy Arnst and colleagues at Yale have done a lot of work that you can actually strengthen the circuitry and maybe help cognition and executive functioning a little bit through actions at alpha-2A postsynaptically by stimulating that. So, it could be a tale of two cities here where you're helping a little bit attention and then also obviously the hyperactivity. I find those drugs to be the best really for augmentation. They're hard to tolerate due to sedation by themselves. And so adding them to stimulants is terrific combinations like peanut butter and jelly.
Well, when you do that, seriously, are you looking for more pro-cognitive effects of the alpha-2 drugs, or are you looking for more behavioral impulsivity and agitation improvement with those drugs?
While the stimulant is in the bloodstream, it's the latter. However, what's the problem with stimulants? The bookend times. They take time to kick in the morning, and they have to wear off at night or the kid won't go to sleep, so they're uncovered. So I really like the alpha-2 agonists. They help cover the bookend times, and they do what you were talking about. And sometimes they do allow you to get away with a little bit lower dose of a stimulant, which may be a good thing. So a lot of different things. Also, their side effects are completely complementary. I mean, think about stimulants raise blood pressure. The alpha-2s lower it. Stimulants make you alert and have insomnia. The alpha-2s are sedating and so on. So it's very interesting.
Well, see, there you've got your bad math, Andy. There you've got your bad math. 1 + 1 = 10 on therapeutic effects, and 1 + 1 = 0 on side effects.
Exactly. So, I was
if you're lucky.
I was an investigator in these trials with the alpha-2s. I'm an author on the paper of the extended release guanfacine added to stimulants. And what we saw was less side effects when you combine these two drugs than either drug alone. We were amazed. So you're right.
Bad math.
I guess
bad math.
Well, that's an example of rational polypharmacy. Of course, we are all too often see irrational polypharmacy, but polypharmacy is not necessarily a bad word, Steve. The fact is that it's done in all fields of medicine. I mean, if you're treating hypertension or diabetes, it's not unusual to combine two different mechanisms. Why is it such a bad name in psychiatry?
Well, I think it has to do with sometimes using two benzodiazepines or two antipsychotics or two stimulants.
Yeah.
And actually maybe not making a lot of sense just throwing drugs at people when you don't know what to do. But you're right, co-therapy, which is as synergistic mechanisms of action. You don't count the number of drugs you give, you count the number of mechanisms that you give. And, the other way to put it is that I just told you that these circuits are controlled by at least two neurotransmitters, dopamine and norepinephrine. So I joke and say, well, if God can commit polypharmacy, why can't we? So in other words, the natural thing in your brain is to have natural neurotransmitters more than one. And you could conceptualize that to put things right, you might need to play upon more than one of them to get maximal therapeutic outcome.
Yeah. I've always thought that the brain is so darn complicated that you need multimodal therapies. I remember in my residency when Prozac was coming out, and they made such a big deal out of how selective it was. Isn't that great? And I had a professor who scoffed. He said, dirty drugs are better. And he meant, of course, multimodal, polymechanism. What's the most effective antipsychotic we have still? Clozapine. You don't get more dirty than clozapine, right?
Well, Brian Roth, who's a famous neuropharmacologist in North Carolina, says we don't want magic bullets, we want magic shotguns. And so that's his analogy, and I think he's right.
Yeah, that's really good. Well, we've talked about kind of what we know about some of the neurocircuitry. We've talked about the common medications, which are the psychostimulants, methylphenidates, amphetamines. We talked about norepinephrine reuptake inhibition. The classic there is atomoxetine. And then we've talked about the alpha-2 agonists, guanfacine and clonidine. But there is a new kid on the block. There is one called viloxazine, and viloxazine extended release is known as Qelbree. What's different about that one? It says in the package insert it's a norepinephrine reuptake inhibitor.
Well, remember, this is an old drug that was repurposed from England, particularly Europe in general, where it was sort of thought of as having norepinephrine reuptake properties, and it was approved in Europe and used in Europe as an antidepressant. It had to be given more than once a day because it had a short half-life. Well, then, because atomoxetine works, an American company brought it back and put an extended release on it so you could use it once a day, and it worked. But you know what's funny about it? It doesn't require as much norepinephrine transport inhibition at its effective doses compared to atomoxetine. And I can remember having a cup of coffee with a brilliant and quite handsome young man by the name of Andy Cutler once, who told me that one of his and they told me that in his trials that people didn't have the noradrenergic side effects of atomoxetine, and it was a quandary. Well, it's partly explained by the fact that norepinephrine transporter isn't inhibited as much, so you wouldn't get that outcome. But then how come it works? And so what has happened in the recent times is it's got at least two other mechanisms. And so that's just been uncovered with modern receptor binding studies. And those extra properties allow you to get the norepinephrine and dopamine effects in the cortex without whacking the heck out of the norepinephrine transporter like you do with atomoxetine. Atomoxetine requires 90% inhibition of NET, but only 50% with viloxazine. So those other things, which are 5-HT2C and 5-HT7 properties, there may be more that will be discovered, but those things render that drug quite different from atomoxetine.
Yes. Well, you know what's interesting about that? So when I did the first trial in America with viloxazine, it was over 10 years ago now, I looked this drug up, and as you said, it was a very effective antidepressant for years. The problem was 3 times a day dosing, a lot of nausea, and so when SSRIs came out, of course, they had less nausea and they were once a day, so they took off, and people just didn't prescribe it as much. So it was taken off the market for those reasons, commercial reasons, not had anything to do with safety. But when I looked it up, it's fascinating. It said this drug increases both norepinephrine and serotonin. It is a norepinephrine reuptake inhibitor, but it is not a serotonin reuptake inhibitor. And they even said in some of the articles I read, it raises serotonin by an unknown mechanism. Well, you're right. The mystery seems to have been solved more recently with the understanding that it binds pretty well to 3 different serotonin receptors, 5-HT2B, as well as 2C and 7. And all of those we know can be antidepressant mechanisms. They can help with cognition and other things. So obviously that's got to be part of the story. As you said, you're adding receptors to this modest norepinephrine reuptake inhibition.
Yep. And I think that the mystery about why you have lower NET inhibition necessary with viloxazine is solved with the 5-HT2C partial agonist properties of viloxazine, because those two things are synergistic. If you work together, they will raise norepinephrine serotonin. But then the 5-HT7 is a very good candidate for explaining why serotonin goes up. You may know that one of the other famous 5-HT7 antagonists is lorazepam, which, of course, has antidepressant effects. So it's led to the possibility that this agent would be useful in some of the mood or anxiety symptoms of ADHD. And the other thing I'd like to ask your opinion about is, there's so much comorbidity in psychiatry, you almost wonder how the DSM works, because if everybody's got 2.5 diseases, 2 full criteria and a few symptoms of a third one, I mean, what are our diagnoses? And in the case of adult ADHD, how many people have anxiety? I mean, it is almost, part of the symptoms. In fact, there's sometimes why you miss ADHD in an adult who's never been diagnosed before, because all you see is the anxiety. And so what happens is that maybe raising serotonin could be a candidate for helping some of those comorbidities that are very common in ADHD. Still under investigation, but it's theoretically possible.
No, you're 100% right. ADHD is a disease of comorbidity. Well more than 2/3 of ADHD patients, both children and adults, have comorbidity. And you're right. The 2 most common comorbidities by far are anxiety and depression. And interestingly, atomoxetine was originally developed to be an antidepressant, and it failed. And when it failed, they repurposed it for ADHD. So clearly, norepinephrine reuptake inhibition alone is not a great antidepressant mechanism. There is one drug approved in Europe for depression. It's reboxetine, but it's not a great antidepressant, to be honest. So clearly, this drug is doing something different.
Well, the one thing I'd like to see is a head-to-head study of viloxazine with a stimulant, because we do know that the effect size, at least, of atomoxetine is, generally speaking, later and smaller than stimulants. And more people don't like it because they don't get the immediate kick, and maybe the outcome isn't quite as big a therapeutic effect. But I'm not so sure that that's the case anecdotally that we're seeing with viloxazine. It just hasn't been studied properly so that we can know how to address that.
Well, I don't know that the effects are going to be as dramatic. I don't know the effect size will be at quite as high as stimulants, which are some of the highest effect sizes in all of medicine. But you're right that this drug, I can just tell you from treating a lot of patients with it, it feels different from atomoxetine. This drug works faster. And the data says within the first 1 to 2 weeks, you might start seeing something. It's an easier titration. It is better tolerated, as you mentioned. Less whacking of net gives you less of the nausea, the gastrointestinal problems, urinary retention, problems with cardiovascular issues as well. So it is really interesting. Now, we mentioned 2C and 5-HT7. 2B is interesting. My friend Vlad Maletic, who is really a whiz on this, has told me that 5-HT2B antagonism is also an antidepressant mechanism. There's 5-HT2B receptors on GABA interneurons in the dorsal raphe, and if you block this receptor, you silence the GABA interneuron and you increase serotonin release, so you disinhibit serotonin. And the interesting thing here is this drug has been shown to increase serotonin, especially in the prefrontal cortex.
Yeah, and that's very unusual because every stimulant plus every norepinephrine uptake blocker don't. And so that's a unique action. So is that going to be an epiphenomenon, or is it going to have a therapeutic target, perhaps depression or anxiety, for the viloxazine adding this third neurotransmitter? So it hasn't been chased down yet, but it seems that it would not be clinically silent to raise to raise serotonin along with dopamine and norepinephrine. So the logical place to look is depression and anxiety that are comorbid with ADHD to see if those get better.
Well, all I have to do is ask our audience, how many of your patients, your adult patients with ADHD, do you have on a stimulant and an SSRI? And I'm sure every hand is going to go that they do that. And so here we potentially have one medicine to treat both. Again, atomoxetine does not increase serotonin. That's been clearly shown. This drug is increasing serotonin in the prefrontal cortex and also, Steve, interestingly, in the amygdala, which obviously is going to help with depression and anxiety. And when we're talking about these comorbidities, I think serotonin's interesting because serotonin's involved with mood and anxiety, but also impulsivity, which, as we've said, is a big issue with ADHD.
Right. So it's going to be interesting to see, as you add these other mechanisms and look for additional things beyond the traditional outcomes of ADHD trials, how that's going to show up, what's going to be the clinical counterpart to these additional binding properties.
Right. And Steve, something else we should talk about. I always say serotonin receptors regulate things in addition to serotonin, right? They do regulate serotonin, but you alluded to this a little bit. Let's talk a little bit more. How can a serotonin receptor regulate norepinephrine or dopamine or something else? How does that work?
Well, it's a circuit. So serotonin talks to things. It talks to serotonin 2C receptors. You would expect that. Serotonin talks to serotonin receptors. Well, guess where they're located? Mm-hmm. They're located on these GABA interneurons, and they're always excitatory. So when serotonin is released on a serotonin 2C receptor, it causes GABA to be spit out. Mm-hmm. Well, that will inhibit anything downstream of that. Those specific GABA neurons, guess what? They're plugged into dopamine and norepinephrine neurons that go into the cortex. So the 5-HT2C agonism will basically shut down dopamine and norepinephrine, which is the wrong way to go. So what you want to do is have 5-HT2C, at least partial agonism or net antagonism, which would cause the serotonin at the 2C receptor to be blocked. And so it can't do the inhibition anymore. Therefore, it's disinhibited and is a little bit, as you just explained quickly, for the 5-HT2B in another circuit. And therefore, you get dopamine and norepinephrine release. Now, people may not realize this, but this story has already been out there for another drug. You may know that the quetiapine is metabolized to a thing called norquetiapine. Norquetiapine is a 5-HT2C antagonist and a NET inhibitor, norepinephrine transport inhibitor. And so at the same time, they kind of discovered that quetiapine was turned into norquetiapine. It was then, developed, quite extensively in the mood depression area. And it's thought maybe that explains a lot of its actions. So this is a story that's out there that those two things working together could have an antidepressant effect. And even though it's serotonin's receptors that you're acting on, you're not changing serotonin. You're saying you're changing downstream norepinephrine and dopamine.
Yeah, same story for 5-HT7, I imagine.
Well, in that case, you are changing serotonin because the 5-HT7 receptor is basically also, those little funny little buggers, those little GABA interneurons, they're full of all sorts of receptors. They're full of 2Bs and 7s and 2Cs, but they're in different places. So the way it's wired is that when you actually stimulate a 5-HT7 receptor, it stimulates the release of GABA, which turns off serotonin. So if you want to turn on serotonin, you stop that. So what you do is you block the 5-HT7 receptors. It doesn't tell GABA to be released. Therefore, you're, again, you can't see it here, but if I give you straight eye contact and wave my hands and say disinhibited, you'll think my IQ is very high because it sounds like a real cool name and a word and so forth. But I got a confession to make. It actually just means you turn it on. So what ends up happening is a 5-HT7 antagonist or 5-HT2B antagonist may disinhibit serotonin release, which means 5-HT7 or 5-HT2B antagonism raises serotonin. And that could be good for both anxiety and depression.
Well, that certainly makes sense. But my understanding is 5-HT7 antagonism is antidepressant, but has other clinical actions as well. Sleep-wake cycle, cognition, perhaps?
It certainly does in experimental animals. It even has pro-cognitive effects. So it's not clear that those have shown up, let's say, for example, in the lurasidone story, which is the 5-HT7 antagonist that people may be most familiar with. But it's also got 5-HT1A and D2 and on 5-HT2A, a lot of other things. So it's possible that 5-HT7 antagonist would help circadian rhythms, would help cognition, would help mood.
Well, there actually was a study with lurasidone. The Pearl 3 study was done in schizophrenia, and the active control was quetiapine Seroquel. And they demonstrated pro-cognitive effects in patients with schizophrenia. And the other one that's analogous is our friend vortioxetine, which has 5-HT1A agonism, but also 5-HT7 antagonism. And as we know, that one has clearly been shown to be pro-cognitive, and they even have an indication for improving processing speed, a form of cognition. So very, very interesting.
That 5-HT7 receptor may explain some of the properties that distinguish, let's say in the case of the ADHD story we've been developing, viloxazine, from atomoxetine for sure, and maybe even from the stimulants, because none of those have 5-HT7 properties.
Right. There's another drug in development. Sunovion has a non-racemic form of amisulpride that apparently has relatively high affinity for 5-HT7 as well, and they're studying it for bipolar depression. So I think this receptor is fascinating. But also 2C and also 2D.
It's available in the racemic mixture in Europe and not ever in the United States, but they have a different mix of the enantiomers that's in testing, like you say, and may have a new bipolar depression drug coming to the United States that way.
Yeah, very exciting times. So again, getting back to serotonin, Steve, is it reasonable to assume that increasing serotonin actually helps ADHD? As far as certainly the comorbidities and maybe impulsivity and maybe various, we know that people with ADHD have significant disturbances of their sleep-wake cycle, for instance. Is it possible that serotonin is helpful?
Oh my God, blasphemy here. Don't you know that the school of ADHD only tolerates dopamine and norepinephrine stories?
Exactly.
But that is actually the dogma. And it could very well be, as you say, that just because we don't have any drugs that work on serotonin that have been shown to work in ADHD so far, doesn't mean that serotonin isn't involved. And like you say, it may not be involved as much in the specific inattention. It might, but it might not be. It may be involved in some of these other circuits. These other circuits we talked about, whether it's orbital frontal cortex, dorsolateral prefrontal cortex, anterior cingulate cortex, are all regulated by serotonin. So they're also abnormal, it's thought, in inefficiency of information processing in ADHD. So it could be that we'll get some more bad math going here, so that if you add dopamine and norepinephrine pharmacology to serotonin pharmacology, one might expect some synergy and improvement of symptoms, and it's ripe for study right now. It hasn't been proven what we just said, but it's certainly plausible.
Yeah, certainly is. I'm reminded of the fact that SSRIs alone do not treat ADHD. If anything, they downregulate dopamine a little bit, and these people will say that they're blunted, they're spacey, they don't like how they feel. So clearly, you can't just raise serotonin enough. And you said something really important, Steve, that I want to highlight, and that is how ADHD presents differently in different ages. With a kid, when they present it's ADHD, it's ADHD. They're getting in trouble in school. They're not doing their homework, right? Adults, very often, it is the comorbidity. It's that anxiety or depression they present with, and that's the tip of the iceberg. And then what do? We give them an SSRI, and lo and behold, they have treatment-resistant anxiety or treatment-resistant depression, when really it's ADHD.
Right. And so we need to be aware of the presentation across the developmental spectrum, including what I already mentioned. Adults come in with an anxiety disorder, and
that's right.
You may not look or be highly suspicious of the ADHD that's comorbid with it. I always say, what is the term called? Problems concentrating. What disorders in the DSM have problems concentrating besides ADHD?
Most of them.
Major depressive disorder, problems concentrating. GAD, generalized anxiety disorder, problems concentrating. Narcolepsy, problems concentrating. All sorts of things.
Schizophrenia, bipolar,
Yeah. So the same circuit doesn't work efficiently, and one would think that, therefore, the treatments that improve problems concentrating in ADHD might work in other disorders and vice versa.
I think a really important clinical point for our audience, Steve, is that anybody that has certainly a treatment-resistant anxiety or depression, you've got to screen them for ADHD. And maybe you need to screen all of your anxious and depressed patients, at least do a preliminary ADHD screen. It's very common. It affects up to 10% of the population.
Yeah. that is a great point. ADHD is conceptualized as being a childhood onset, but actually worse than that, a childhood disorder, not an adult disorder, particularly by too many people. And so, particularly if it hasn't been robust diagnosed before age, even the old days, 7 or 12 today, that's basically, you can't have that. It's not, you can't diagnose what you don't think of. And generally speaking, when you see adults, you don't think of ADHD unless they bring it to you and say, well, I have ADHD. If they've never been diagnosed that way, it's often missed.
Well, Steve, you want to hear something funny? When I trained back in the dark ages of the late 20th century, there was no such thing as adult ADHD. I was literally trained this was a childhood disorder and you outgrew it, which never made sense to me. This is a highly genetic neurologic wiring problem that you can demonstrate abnormalities on neuroimaging. How could you outgrow that? There's no other clinical diagnosis that does. And what happens, of course, is our brains change and we have coping skills, and the hyperactivity tends to go more internal. You're less overtly hyperactive. And so really, it does persist for a majority of people. It just can look different, or people can find an environment or a situation where it's less of a hindrance and they can compensate.
Yeah. And so you made a really good point. I was trained the same way. I was trained actually in the 19th or the 18th century. I'm not sure which one, so it was a while ago. But the idea is that this was a childhood disorder, not just onset, but a disorder of childhood that you outgrew.
That's right.
And there may be some maturation of the cortex which occurs, and maybe some people get fewer symptoms. In fact, to a certain extent, we joke about the fact that men don't grow up as fast as women do, because this maturation of the prefrontal cortex in men actually normally is delayed until the mid-20s, until it's really robustly done. So it's possible that there's a subset of people that have onset in childhood and just, kind of mature in their 30s or whatever, their cortex catches up, or at least it somewhat catches up, so the symptoms go down. But that's not the majority of the cases. And as you said, is there a psychiatric disorder with a higher genetic load than ADHD in our field? And the answer is I don't think so.
There is not. No, ADHD is almost as genetically determined as height, and we know how genetic height is. The other important point to be made here is that, Steve, did you know there was a landmark article published January of last year in the American Journal of Psychiatry on ADHD? A woman named Maggie Sibley and colleagues did some remarkable studies where they followed kids for many years into adulthood. And you know what they found? That our traditional estimates of what we call persistence of ADHD were wrong. I mean, certainly you and I were trained that you outgrow it, but more recent studies have shown about a 50 to 60% persistence into adulthood. But that was based on point prevalence, looking at one point in time. Sibley and colleagues followed these people for years, and you know what they found? Over 90% of the time it persisted into adulthood, but it waxes and wanes with respect to the disability and the symptoms based on the environment and stress and how well you're compensating. So it can be waxing and waning, and this can be how people can miss it. Steve, a lot of times people present to me when good things are happening in their life. If they have another child, or they get a promotion at work, or they want to go back to school or get a certification. And that's when the wheels fall off, and that's when they present, when it should be a time of good things, but their cognitive demand is going up. And so this shows you how it can be waxing and waning. And I just want to encourage people to read that article. Maggie Sibley and colleagues, it was January, American Journal of Psychiatry, January 2022. Really a landmark article, in my opinion, and a lot of people in the ADHD world really lauded that article when it came out.
That's great to know.
Well, that may be new for a lot of our audience, too. That's new. That might be a new idea.
Well, the waxing and waning part, I think, is not well appreciated. But what disorder in psychiatry doesn't? So it shouldn't surprise us.
Good point. Yeah, there's such an interaction between the environment and stress, of course, and these things. Well, let's talk a little bit about what the future holds. There are some medications in development. There's only one that's on the near-term horizon, and that's called centanafidine. And centanafidine is a fascinating molecule. It's actually a triple reuptake inhibitor, Steve. How long have we been hearing about triple reuptake inhibitors being developed? Isn't that the holy grail?
Yeah,
long time. I've studied many of them. The problem has been getting the ratio, of a transporter binding right, And
well, if you have too much dopamine, you have an abusable drug, and a lot of new drug developments don't like this scheduling.
That's right. Well, there was a drug, dasotraline, that Sanofian had that I was involved with that was highly dopaminergic, for high affinity for DAT, and it also had a long half-life, and it got killed because it did lead to some psychotic and manic-y symptoms. It was a little hard to tolerate.
Too much dopamine.
Too much dopamine is not a good thing. It's what it is. It's really a shame. There's this evil curse word that I've heard called moderation. I can't wrap my mind around it. And Mark Twain even said all things in moderation, including moderation, which I thought was interesting.
I've also heard it a different way from attributed to Benjamin Franklin: nothing in excess, including moderation.
Oh, well, there you go. That's a good one.
So the idea is that most of our patients aren't moderate. They're outliers. Yes. And so, the idea that you're going to have one size fits all and that you can't have, side effects at all, kills drugs. And so, certainly you don't want to have dangerous side effects, but maybe we can match them to the patients that it would help and avoid those side effects.
Well, yeah. And obviously, though, efficacy is critical. Steve, I've studied lots of different sexy mechanism drugs for ADHD over the years. I've studied H3 receptor drugs. I've studied glutamate drugs, and none of them have really panned out, largely due to not having robust enough efficacy. There was even a drug at one point, a company called Alcobra had. It was a variant of a B vitamin that was supposed to help with inattentive type, but none of these things really panned out. And there really aren't a lot of drugs in development right now on the near-term horizon. There are a few kind of off in the distance. Most of our newer drugs, frankly, have been reformulations of stimulants. They've been interesting delivery mechanisms to extend the release or the duration of a stimulant. But that's why this viloxazine is so interesting. It's only the second non-stimulant ever approved for adults with ADHD, and the first non-stimulant approved for adults in over 20 years. But getting back to that centanafidine for a minute, I want to tell you a quick story about how that was discovered. There's a name you certainly would recognize. Frank Bymaster was the genius at Lilly who worked on Prozac and Zyprexa and Strattera and duloxetine Cymbalta. Well, he was hired by a company that had in-licensed a portfolio of triple reuptake inhibitor drugs, and he played with them and found this one, centanafidine. He pointed to that and he said, that one for ADHD. And so it was developed for ADHD, and it's now in phase 3 testing, and it is a triple reuptake inhibitor, and the affinity for NET goes in this order. It's highest for norepinephrine, then dopamine, then serotonin. So it's an NDSRI, if you will, and it seems to have not too much dopamine. And it's not really abusable because as you push the dose, the serotonin effects kick in and it becomes aversive. People get gastrointestinal effects. They've done human liability studies. So this is another fascinating drug that also can increase serotonin. It's a triple reuptake inhibitor.
Well, let me ask you this. Is it likely to avoid getting a Schedule 2? And if it does, the other question is, will it, like we were discussing for viloxazine, possibly be good for anxiety and depression comorbidities with ADHD and attention?
100% yes to the latter part of your question. The first part of the question, at this point, it is tentatively a Schedule 4. It is going to be scheduled most likely, and that's simply due to the affinity for DAT, right? Because norepinephrine reuptake inhibitors are not scheduled. So this is a theoretical risk, even though there have been several human abuse liability studies done with this drug, and drug addicts don't like it. It is not abusable because of the serotonin effects, if you will. So unfortunately, so far, the DEA is looking at this and saying, well, you look kind of like a stimulant. You've got dopamine transporter inhibition, dopamine reuptake inhibition. So hopefully the company, Otsuka has it right now, is developing it. They're going to try to make their case. And I would hope it would not be scheduled. I don't understand why it should be. But if it does, if it's Schedule 4, that's not a deal breaker. Schedule 2 would really make it difficult, as we know. It's very hard to prescribe Schedule 2 drugs these days.
Right. Yeah, while we're talking about other drugs that are used, tell me, what do you think cannabis does? Because most of our patients smoke cannabis. What does it do for ADHD?
It's fascinating, Steve. What I've noticed clinically is cannabis for ADHD patients is a love it or hate it drug. There is no in between. Some people with ADHD swear by it and they say it helps their attention and especially it helps their anxiety. Some people hate it. They get agitated, they get paranoid, they just don't like how they feel on it. So clearly ADHD is a heterogeneous condition and we're uncovering two different biologic forms of ADHD, if you will. But the research on cannabis, as you well know, has not been too impressive to date for psychiatry, has it?
No. I mean, some of the, the cannabidiol, if anything, is a little bit more interesting in that it may be anxiolytic, may help a little bit in pain, but the cannabinoids are toxic and they actually cause psychosis and activation, and they're not well tolerated, so an anxiogenic.
Exactly, and that's what studies have shown, and yet we all anecdotally have patients who swear by it for their anxiety or some other conditions. And, cannabinoid receptors are ubiquitous in the brain. They are linked to very interesting systems like opioid and dopamine and others. So, and those receptors have to be there for a reason. There are endocannabinoids in the brain. And you would think you'd be able to manipulate them somehow therapeutically, but so far we haven't figured it out.
Well, it's something to keep in mind, though, for this audience, is that if your patient's not responding to stimulants, suspect cannabinoid use, that even if they're not telling you about it. Because, I mean, the stimulants work pretty well in a lot of percentage of the people.
That's right. I really agree, Steve. One of the things that I try to do is I try to take a non-judgmental approach, and I tell people, look, you are self-medicating something in your brain, and I'm going to give you a legal and more efficient way to do it. And with a stimulant, you may not need the marijuana anymore. We're going to try to give your brain what it needs to function better. Some people are still going to swear by it and use it, but there is a concept, Steve, called harm reduction. It's not necessarily all or none. It's not get them to quit completely. If you can get them to cut back and reduce the harm, that's certainly a good thing.
Yes, particularly if they're not responding robustly to your stimulant treatment, for example.
Yeah, I really agree with that. That's an excellent point. That is to screen for that as well. And other drugs of abuse as well, and also alcohol and other things. It's interesting, like everything else in medicine, dietary and lifestyle behavioral modification can be helpful. For instance, there is excellent evidence that exercise is highly beneficial for ADHD. So it's good for the brain, if you will. It dissipates energy, but it does a lot of other. It increases dopamine release and endorphins. Certainly, we know there's diet interventions. We know that sleep deprivation is horrible for people with ADHD. They just don't do well with that. So in addition to medicine, we've got to do these other things.
Good point.
There's even supplements that may be helpful, not as an alternative to approved medications, but in addition to. Again, anything that's healthy for the brain could potentially be helpful and healthy here. Antioxidants and other things, So there's a whole new frontier here. And that's one of the questions, of course, is what does the future look like for the treatment of ADHD? Another vista we haven't talked about, Steve, is digital interventions. There's several of those in development.
Right. And all throughout psychiatry, not just for ADHD. So, types of psychotherapy and even CBT for insomnia and all sorts of things. So it's, if you have a mild case or you want to supplement your stimulant, then these things are helpful.
Yeah, I absolutely agree. There is one that's FDA cleared and on the market. A company called Achille Interactive has a therapeutic video game called Endeavor RX. I was involved in the development. I'm an author in the paper of that one. And there's another one in development, several others, I should say. There's also an FDA cleared device. It's a trigeminal nerve stimulating device, believe it or not. A company called NeuroSigma has this, and it was validated by a study out of UCLA. And this is putting a patch over the forehead of your kid, and they before they go to bed, and they sleep, and it stimulates. And there's some evidence it can work. So, this is really we're going beyond the pill, aren't we? Going beyond traditional medicine.
Absolutely. Well, and like they say, there's an old saying:
Yeah.
There's an old saying, there's no skills in pills.
Yes, pills don't teach skills.
So if you want skills, you get symptom reduction. If you want skills, you need is therapy or something else.
Yeah. Well, speaking of that, there are many forms of compensation. I think with the advent of some of our technology, certainly smartphones have been a godsend for people with ADHD. They can keep track of things and set alarms and reminders. There's a whole discipline called ADHD coaching, which is not psychotherapy. These are people who actually coach you and help you learn compensation strategies and stick to a routine, for instance. So there are other things because, to be honest, as I mentioned, there's not a whole lot of new medicines and innovation in development, to be honest, for ADHD. It's been very hard to find medicines that are just as darn effective as stimulants. Ideally, we'd like to find ones that are not abusable and that are better tolerated and safer and so on. But that's really held us back a little bit.
Yeah, I agree.
All right. Well, Steve, the time always seems to fly by when we have these talks. We're going to have some other shows in this series and get some other takes on ADHD, which, as you well know, when we poll our members at NEI, ADHD is always one of the top things that people want to hear more about. This is a very hot topic. And so we'll have an opportunity to dig into it even further. Thanks so much. And to our audience, please stay tuned to the other podcasts in our psychopharmacology series. And for more information on our products and services, please check out our website, which is www.neiglobal.com. That's neiglobal.com. And you'll find all kinds of great things there. And you can even become a member. So thanks so much for listening. Thanks, Steve.
Bye-bye.
Thank you so much for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.